Thank you, Per. This is definitely too flattering, but I hope... Oh, this is the other Peter's lecture. Could you... Oh, I'll give his lecture and he can give mine. Mine is very straightforward. Because in general, I do appreciate the people of the lower airway respiratory field even more than the upper respiratory field because they're more intelligent in general. But anyhow, let's try to get the slides of precision medicine in rhinology. And precision medicine is now very hot. It's very much en vogue because it will pave the way for better treatment options in our patient population affected by rhinitis, rhinosinusitis, and those in which we perform sinus and nose surgery. I would like to guide you through some of the reasons why we should be interested in precision medicine and why this is implementable into our daily practice. So the why, what, and how of precision medicine is part of what I will be sharing with you today. We are clinicians dealing with patients affected by rhinitis, rhinosinusitis, and from multiple studies, we know that about 1/3 of the patients affected by allergic rhinitis, as well as those affected by non-allergic rhinitis, or 1/3 is uncontrolled. There are multiple reasons for being uncontrolled, but multiple studies, including our own work, highlights that rhinitis patients have a significant degree of uncontrolled disease, and real-life data that are generated by the mobile health tools all confirm that up to 35% of these patients are meeting the criteria of uncontrolled disease, and the same applies for those having rhinosinusitis and even after sinus surgery. If you contact your patients at 3 years after surgery, up to 40% of those meet the EPOS criteria of being uncontrolled, with the mean VAS score of about 5. So this is quite high, and this is the reason why uncontrolled disease is a daily challenge for all of us. Patients may be dissatisfied due to uncontrolled disease, but especially in the field of rhinoplasty, and many of you are involved in rhinoplasty practices as well, up to 35 and 40% of the patients reported in trials are dissatisfied with the result after rhinoplasty. We as ENT community do not invest sufficient amount of time in the prevention of asthma. We do have the scientific tools now to arrest the progression from rhinitis to asthma by the implementation of immunotherapy. And we do have the scientific tools now to stop the progression from chronic sinus disease to asthma, but this knowledge is not promoted and is not implemented into daily practice yet. And due to the fact that we do not invest too much into prevention of disease and the prevention of progression of the disease, there is a huge socioeconomic impact of patients affected by rhinitis and chronic respiratory diseases in general. This is the reason why precision medicine is important, because we want to achieve a higher level of control of our patients. We want to reduce the socioeconomic impact of chronic respiratory diseases by implementing the 4 Ps of precision medicine. And we did not invent precision medicine ourselves. It was actually President Obama who launched the Precision Medicine Initiative in January 2015 as the way forward in the field of oncology. But by extrapolation of the principles of precision medicine, personalized care, prediction of success of treatment, prevention of treatment if possible, and prevention does not only include primary prevention, which is prevention of the disease occurring, but also secondary and tertiary prevention, and also patient participation in the definition of the treatment strategy. By implementing these 4 Ps into daily practice, we conceive or we might achieve a higher level of control and prevention of progression of disease. And precision medicine is often associated with molecular diagnosis, big data, pharmacogenetics, and all the omics that we may think of and that I do not understand. And all these complex analyses pave the way for the future, but for us clinicians, we are far from there. And I would like to share with you what is really needed and how we can already implement precision medicine in respiratory care. And just a couple of months after President Obama's initiative and launch for more precision medicine in oncology, We launched a symposium at the European Parliament with the European Rhinologic Society as well as European Academy of Allergy Clinical Immunology, where we promoted also precision medicine in the field of respiratory care. And we decided that it's time to act based on novel scientific data that allow us to predict disease development, to prevent disease progression, and to allow targeted treatment, including endotype-driven treatment. We have novel therapeutic strategies, new diagnostic tools, and also benchmark practices. And I can give you the example of the Finnish allergy and asthma program, where they managed to reduce hospitalizations for asthma by 40% in 6 years' time by the implementation of better education and better strategies. And part of these strategies match the principles of precision medicine. As there was the need to also join forces for implementing precision medicine into daily practice, Euphoria as a non-profit organization was also developed and founded in 2015 with 4 key pillars: a research pillar, education pillar, an advocacy pillar, and digital solutions that would all allow a patient-centered approach in achieving the goal of bringing precision medicine into daily care. We will have a precision medicine or a Euphoria symposium at lunchtime, and I kindly invite you to attend there. But we now try at an annual base to organize events at European Parliament at highly political level, engaging WHO and also the European Commission and United Nations into what we believe is important for prevention and self-management and better care for patients affected by chronic respiratory diseases. Having said that, we now developed a Vilnius Declaration where we try to achieve better support from health policy makers all over Europe in order to achieve better control of respiratory disease. Coming back now to the everyday life of a patient. This is a man, an adult patient, coming to see me for nasal obstruction, headache, loss of smell, and some secretions. When we do the proper diagnostics, he turns out to have a house dust mite sensitization. He has chronic rhinosinusitis with nasal polyps, confirmed by nasal endoscopy, and there is some nasal valve problems as well, as you can appreciate. So this patient, if you would just focus on one of these 3, will never get a high level of control, and you need to be able to deal with both the allergic component as well as with chronic rhinosinusitis as well as with the anatomic problem in order to achieve a good level of control. So how do we implement precision medicine into daily practice? And I will guide you briefly through the implementation in rhinitis, rhinosinusitis, rhinoplasty, and sinus surgery. When we think of the 4 Ps, we cannot expect a primary care physician or anybody, a general ENT doctor, to go for the 4 principles of precision medicine being implemented at a primary care level. I mean, prediction of success of any treatment in patients with allergic rhinitis can be achieved, as well as participation of the patient in the decision-making process for nasal or oral treatment, monotherapy versus combination treatment. And this does not exclude following the guidelines, but this is just a discussion about the treatment options and what would be the treatment that the patient is most adherent to, achieving the highest level of control. Prevention strategies can be implemented as a next step depending on the level of control achieved and depending on the need also to prevent the progression to a more chronic, irreversible state of disease and asthma. And then the personalized care should be implemented at tertiary care level, including endotype-driven treatment, because this is actually what we are dealing with at academic level. And this graded implementation can be associated with the treatment algorithms that have been modified from the ARIA guidelines, where you can implement these principles in a graded way. You're familiar with phenotypes of disease. So the phenotypes is the clinical presentation of the disease with the different symptoms, and the phenotypes are listed here based on severity, duration, sensitization pattern, and comorbidities. These phenotypes may have underlying endotypes, and we are now performing a significant degree of research in the neurogenic phenotype, the epithelial phenotype, but this is far from your daily practice. It will help us to better understand the pathophysiology and also design novel treatment strategies like the capsaicin for those with severe neurogenic inflammation and high substance P levels, or epithelial restoring strategies for those in which the barrier or the epithelial layer is dysfunctional. I will not go into detail because this is far from our routine work. This is good for research, but not so much for your daily practice. If we then go to the graded implementation of the principles of precision medicine into rhinosinusitis, we come to a similar kind of approach that we could recommend. We predict the success of the treatments with steroids, antibiotics, nasal douching, and the other treatment options that we might recommend to our patients. Also here, the secondary and tertiary prevention of chronic rhinosinusitis, also leading to asthma in 1/3 of the patient with CRS, is important to consider, and also the endotype-driven treatments where we have nowadays novel options emerging, and these options, you heard a lot about them during previous lectures. Also here, we can include the graded implementation of precision medicine into the treatment algorithms. If we talk about biological treatment and endotype-driven treatment for chronic sinusitis, we need to go to this scheme where we have defined phenotypes in relation to endotypes in chronic rhinosinusitis, and actually we are not that far yet as to know what biomarker will predict a good response to treatment. And what is important for us as an ENT surgeon and rhinology surgeon is who should we recommend surgery in, and when would be the best time for surgery. And you're all aware of this study that was led by Claire Hopkins and the team in the UK, showing that the earlier patient get access to optimal treatment, including sinus surgery, the better the outcomes of surgery and the lower percentage or the lower prevalence of asthma in the patients of the early cohort compared to the patient that had a delay of more than 5 years before getting access to sinus surgery. And this is actually what the Euphoria team is also trying to achieve: timely access to optimal and effective treatment, allowing effective treatment to be implemented, and we as scientific communities being able to monitor the outcomes of the effective treatment in order to convince health policy makers that upper respiratory diseases are important and that we should have access to reimbursement and registration of new therapeutic options. And one of the key products that Euphoria has been investing in significantly with the whole team was the development of a digital tool that would help the patient in order to get more education and a higher level of partnership with the doctors. And this is the My Sinusitis Coach, which is a mobile health tool helping the patient not only to fill out their daily symptoms on a simple VAS score, but also build a true partnership with the doctor where both the patient as well as the doctor get feedback on the degree of symptom control in relation to medication and surgery. Due to the fact that this feedback is also associated with educational material based on Q&As, patient testimonials, and also relevant questions of the patient answered by some KOLs. This is really appreciated by the patient, and most patients use it for more than 3 weeks, which is a major achievement in the field of mobile health tools. So this is My Sinusitis Coach. Some of the people here at the exhibition hall might give you more information about that. There are multiple benefits of this tool, not only the patient benefit from it, but also the doctors as well as the research communities and the health policy makers, because we join forces in order to have these patients reaching a higher level of disease control. When it then comes to position in the future the treatment option of biologicals in relation to sinus surgery, we need some careful discussion about it and also clearly position the future option of endotype-driven treatment, including all the biologicals that are now in phase 3 trials and that will hopefully be registered in the coming years. And this is just a brief summary that is available online in the new official journal or the new online journal of the European Rhinologic Society, the Rhinology Online Journal, where you find some suggestions of a brainstorming session on who, where, and when endotype-driven treatment should be included into daily practice. And as you know, endotype-driven treatment is based on the knowledge on the inflammation that is present in the tissue of patients with chronic rhinosinusitis and nasal polyps, where IL-5, IL-4, and IL-13 and IgE are the key targets of what we currently have available as biological treatments for patients with chronic rhinosinusitis and nasal polyp. And I would just like to share with you one of the key publications and key molecules that we have nowadays, DUPILUMAB, which is blocking IL-4 receptor. And this is a study showing the major potential of DUPILUMAB, for instance, in patients with chronic rhinosinusitis and nasal polyps, where we do not only find a significant reduction in nasal polyp score, as well as improvement of nasal breathing by improvement of the peak nasal inspiratory flow, but also reduction of snot scores and also improvement of smell. This is significant. But what is important to know is that we not only treat with these systemic treatments the upper respiratory tract, but also the lower respiratory tract. So also in patients with comorbid asthma, we do find a significant decrease of lower airway disease parameters. And I will not go into detail, but what I conceive as important, or what I consider to be important on biological treatment, is that efficacy can go up to 80% of patients affected by chronic rhinosinusitis and nasal polyps, and this efficacy is achieved on top of nasal steroid treatment. It is effective on both upper and lower airways, and it's effective on chronic rhinosinusitis, nasal polyps, and comorbidities. But we are still debating on the position in the care pathways, the preventive potential, as well as the superiority of the one biological over the other. And what are pending issues, for me at least, is the long-term efficacy and the cost versus existing treatments. And I would like to go also into rhinoplasty, because rhinoplasty is, for me, one of the key examples of precision medicine, and I will guide you through one of the concepts there. The 4 P's of precision medicine are very carefully and very nicely reflected in the daily care of patients that come to see you for a rhinoplasty. As these classical parameters that we take into account at the preoperative consultation do not suffice for patients in rhinoplasty. You may be aware of the fact that the majority of studies looking at outcomes in rhinoplasty show that 65% of patients are really satisfied with the rhinoplasty, and 35% might not be fully satisfied. Due to the fact that we do implement the principles of precision medicine in daily practice, we now reach 93% of satisfaction, and I will just guide you through some of the principles that we implement in daily practice. First of all, we have the patient as an active partner in the decision-making process of the procedure. We discuss surgical versus non-surgical options. The approach is being discussed based on what is feasible and what is needed for the patient and what the patient wants, and also the different types of grafts and the ideal material is discussed with the patient. This is, for instance, a patient coming to see you just for a correction of the subtle concavity here and the asymmetry at the level of the middle cartilaginous nasal vault. You need to discuss with her whether or not you would consider a non-surgical rhinoplasty with a filler, or you could consider surgery that is minimally invasive by insertion of a camouflage graft, which could be fascia, which could be crushed cartilage, Or some of our colleagues, if you would present this case in a panel, would go for very invasive and structural rhinoplasty, including spreader grafts, and some would even consider rib cartilage in such a lady, even in a primary case. So I think it's important to discuss with these type of patients what are the opportunities, what are the options, and you finally come to a conclusion on the strategic application of a surgery plan based on proper education of the patient, and in that way you build a trustful relationship. In this man coming to see you for a functional rhinoplasty with nasal valve dysfunction and some alar collapse, we first tend to try non-surgical options, including the dilators, because these dilators should be recommended, according to my opinion, not only as a good therapeutic option, but also to educate the patient better about what to expect from surgery. Because if they apply these dilators and they are still not satisfied, you know that you shouldn't do a surgery, because you will never achieve the same result with surgery as with these external or endonasal dilators. I don't have any conflict of interest here, but just would like to mention that we did a trial on the objective improvement of nasal breathing with these different dilators, and the endonasal seemed to be more effective in opening the nose than the external ones, with a mean change in PNIF, or improvement of peak nasal inspiratory flow, of up to 33% by these dilators. But what is typical for precision medicine and what is implementable into daily life is that we offer the different dilators to the different patients, and as you can see here, some prefer the one, some other patients, and 1/3 prefers another dilator. So this is very personal. And therefore, I do think it's important to discuss these options also with the patient. And after 1 month of a trial period, half of the patients still want to use the dilators, half decide to go for more structural solutions. And there you can consider surgery, as we did in this patient, where we just inserted in an endonasal way some alar batten grafts, which is a procedure that only takes 30 minutes. If you associate it with a hump reduction, it's a very straightforward, not so complicated solution, which might help your patient better. But nowadays, for these type of patients, we go through a phase of non-surgical options first, and then we implement the surgery. The same discussion we always have about the closed versus the open approach in rhinoplasty. Some surgeons do all cases open, others are considering the open approach too aggressive and do most of the cases in a closed approach. For me, I consider several patient-related factors like the age, the deformity, and the preference of the patient as key in the decision-making process of what approach you will use. And the same applies for the surgeon-related factors. The skills of the surgeon, the preference of the surgeon, and also the attitude determines what approach is finally applied in daily practice. And in my own practice, I do half of the rhinoplasty closed and half open, reflecting this type of personalized care. This is, for instance, a lady willing to have just a subtle refinement of the tip and more symmetry here at the level of the lateral crurae. I do not think it would be the best option to open the whole nose and to restructure with graft material this nose. So just by an endonasal transcartilaginous cephalic resection and some suture materials, you can reach a result that is acceptable. And the major change is actually performed in basal view, or can be appreciated in basal view, where the alar base is also narrowed. The same applies for the graft material. It's good to discuss with the patient the different options that are there. You need to be able to work with the different options in order to be able to discuss these options with your patient. She had 2 rhinoplasties before. She had a saddle deformity. But for me, autologous rib cartilage is always superior to other types of commercially available cartilages from the tissue bank. But anyhow, this is it. I think a 2-year post-op result. She was wearing the same earrings, but anyhow, here the long-term result with own cartilage is always preferred, especially in the multiple revision noses where you want to prevent massive resorption if you would use irradiated rib cartilage. Anyhow, also prevention of revision by several techniques that are now really recommended highly during courses can prevent revision rate. And prevention of dissatisfaction can be done by a proper patient selection, and I think that is key for success in rhinoplasty, irrespective of the deformity. We validated a screening tool for body dysmorphic disorder, and in our patient population, 35% of the patients meet the criteria of body dysmorphic disorder, so this is not neglectable, and you should not refuse to do surgery on those, only in those with severe body dysmorphic disorder, which is only 5%. But it's good to have a screening tool, and beside the screening tool, two-dimensional morphing is key, where you discuss with the patient the change in the nose, first in side view and then in front view. And the reason for me to do this is you get to know the personality of the patient better. And if this patient, for instance, would not be satisfied with the result that you consider perfect, then you shouldn't perform the surgery because you know on beforehand that this patient will not be happy. She can discuss with you that some changes are not meeting her expectations. And the same applies in front of you, where you just do the simulation with the Photoshop program. So this is not extremely costly. And what was striking in the recent trial that we did is that indeed, by doing this, you modify the expectations and you meet more the patient views on what is really needed and what could be the result of rhinoplasty. Nowadays, we invest a significant degree of efforts also in three-dimensional morphing, which is even more elegant and which is nicer to show off to your patients. There is technology available that is really not expensive and that is very user-friendly. So the Vectra technology, for instance, can be implemented into your practice. It would only take you 10 minutes to make 3D images and show to the patient what could be the result. And in those patients that are really in doubt and that are really suffering from the thought of not knowing exactly what they want, we now perform 3D printing, which is the way forward in some patients. It's only in a small percentage of patients where we collaborate with a company in the US in order to have the faces printed. The patient is helped before surgery, and we are helped during the surgery as a surgeon, because we know and we have the model in real dimensions of how the nose should look like according to the patient. We can predict the success of treatment based on multiple trials that have been performed, and there it's very important to predict the success at aesthetic level as well as the results at functional level, because there is not always a match, as is highlighted here in a study where we achieved aesthetic satisfaction in 90% of the patients, but only functional satisfaction in 60%. So we should discuss that on beforehand in order to modify the expectations. So I think the 4 key factors of precision medicine are implementable into daily practice of rhinoplasty without a high cost. We might feel like Mr. Bean at the end of rhinoplasty, but we should know that surgical skills are key to achieve good results, but what is behind and the whole implementation of precision medicine is even more important. So this man, in order to achieve full disease control, was subject to allergen-specific immunotherapy, and he received the FESS at the time of a rhinoplasty. And when we open up the nose, we always try also to achieve a better aesthetic result. He had spreader grafts and Ehler batten grafts, and actually it's mostly in side view that you can appreciate the opening of the nose, and this is also key to success. If you would just treat him with expensive biological treatments, for instance, his breathing would not be better. He might smell better, but his breathing can only be better when you also consider the structural anatomic problem. So having said all of this, precision medicine is implementable into daily practice in rhinology. There are still several challenges to overcome, And if you would like to know more about the immunologic background of rhinitis and rhinosinusitis, we also invite you to the annual Congress of the European Academy of Allergy Clinical Immunology in Munich in 2018. And if you would like to join us one day at a meeting where we brainstorm about research needs and priorities in Europe, you're mostly welcome to join one of these research fora organized by Euphoria. Thank you very much for your attention.